Dear friends, good morning. This is my third topic on the brain tumor, which is brain tumor radiotherapy planning. So, first part we have seen the molecular oncology of a brain tumor. Second, we gone through the recommendation of radiotherapy, surgery, and alkalizing agent based on the molecular marker. And this is my third topic precisely for the radiation oncology postgraduate students for how to go for brain tumor radiotherapy planning. Just a reminder, the most common primary brain tumor result is lethal due to infiltrative nature of high-grade gliomas. That resection margin you don't get, so that the surgical resection alone provides only 6 months. Combination of surgery and radiotherapy improves survival, goes up to 1 year. And if we further combine surgery plus radiotherapy plus temozolomide, it improves survival up to 1.5 year or more than that. The ESCO recommendation that I've already told you, the fractionation radiotherapy improves survival versus temozolomide tablets alone in the old frail patients. Radiotherapy should be started 3 to 6 weeks after the surgery. Adding temozolomide as a concurrent to radiation improves survival versus RT alone is the standard of care as of now. And then the patient who's having a good KPS more than 70 and general condition is good. Optimum dose for a high-grade glioma is 60 gray in 30 fractions. Elderly patient with a poor performance status, I've already gone through the 70, less than 70 kps, and then radiotherapy 60 gray is not superior to 40 gray in 15 fraction for daily bringing the patient to the radiotherapy department. And then if the result is equally good, then 40 grain 15 fraction should be given. So different type of brain radiation is being given, as the whole brain radiotherapy is being practiced of multiple metastatic brain tumors, whole brain radiotherapy, and then we go for a conformal radiotherapy, then the 3D radiotherapy planning, and then further zeroing the stereotactic radio surgery or stereotactic radiotherapy. And from low dose, here you see we are extending to high dose and a more precise radiotherapy and almost negligible radiotherapy to the normal tissue in stereotactic practice. Post-op brain tumor CT to be done after 21 days by the radiation oncologist. And then, because we don't want to treat edema, we want to treat the tumor and potentially recurrent site. So that's a research article that says that one must go through that the 20 after 21 days the blood-brain barrier is stabilized, so that brain edema is less seen on the CT scan, so that you don't get confused with the brain edema and the recurrence of a tumor, particularly in the CT. You see in this image that after 21 days, almost 22 to 42 days, in this image you see the brain tumor is almost stabilized. After the post surgery, the cavity stabilization is done, so that it is better time to get a CT scan done. That you can go through this article, the consensus contouring guidelines for post-operative completely resected cavity for a stereotactic radiosurgery for a brain metastasis by the Radiation Oncology Journal. So the contouring following the following norms, the what structures to be is addressed upon. First, the adjacent dura to the cavity where the surgery is performed, the adjacent dura and the surgical tract. Bone inner flap to be taken, not outer flap, and the cavity proper, dural sinus, and then in the surgical intrasurgical tract, any enhancing area should be taken, and the margin recommended is only 5 to 5 mm or to maximum 10 mm. After contouring, we all do what we do. We contour each and every CT slices these structures where these are coming, and now go for a CTV deletion after that. And after that, we go for a CTV, and then PTV, and then we clubbed all the images of a CT scan and go for a DRR imaging, digitally reconstructed image on the treatment planning system, and then we adjust the beams, and the physicists do rest all the things. So I've already told regarding this thing. The resistant dura is taking beautifully taken here, indicated. You see here, bone inner flap is being taken, and then a cavity proper is taken. Any and then dural sinuses, the overlying that cavity should be taken into the radiotherapy planning under the contouring, and any enhancing area around the surgical tract, that is a potentially recurrence area, might recur the tumor, so that you take this thing. Now, after taking all these things, you contour all and deletion that, and also follow the basic principles of ICRU, that you first taken a GTV, CTV, then ultimately PTV, the planning tumor volume, which is the main area of irradiation for you. So here you see here the multiple CT slices, you contouring done, and the volume of a data you have created, and then contouring, merging all these slices, you see the DR image, which is seen on the TPS, a DR image, and ultimately get the tumor plotting in each and every slice on the contouring, and then merging them, and then you go of focal radiotherapy planning. So this is all about the radiotherapy planning regarding the brain tumor post-op, precisely speaking to the on the post-op radiotherapy planning. Thank you very much.